is there in cancer treatment, or cancer is still a deadly disease?
So
So
before you go to your topic,
yeah,
can I just do the formal introductions here, sir?
yeah. So well, I am Dr. M.V. Chandrakant. I am a medical oncologist working in Narayana Hospital, Calcutta. So I'm a classmate of Dr. Abraham. We have struggled together in TMH in the same wards. So we know each other like that. So we learned together, we have struggled together, and it's a hard way we've come up. So at present, I'm in Narayana. I'm basically from Bangalore, but somehow I have been settling in Calcutta as of now. So I treat all both solid tumors, and I treat liquid tumors both. So I have done my fellowship in hemato-oncology, and then I have done my course in medical oncology from TMH Mumbai. So this is how all about me, and I would again thank you guys for providing the opportunity and having an opportunity to speak on this subject. Is it okay, Renji sir? Is it okay? Can I go?
Yeah, I think you can go forward with your topics, and then I'll introduce you people again.
Sure.
Thank you.
Thank you. So, as an oncologist, how I look at cancer, I'll just be speaking. And so we all know that cancer looks like crab, whether it's an actual crab or whether it is a zodiac sign, it's cancer. And the cancer cell, the way it looks in a microscope is like crab, and that's the reason. And the Westerners always have the habit of labeling anything that is under the microscope for whatever food they see, like pepper salt appearance, anchovy sauce appearance. So whatever they say is always food, and even crab probably look to them like food, and probably for that reason they have named these cells that cling to the surrounding structures like a crab, and that's why probably the word cancer has been there for such a disease. Uh, so if you look into what is the difference in cell division between a normal cell and a cancerous cell, is a normal cell has a lifespan. It is it is born, and after some time it stops multiplying and it dies on its own. So there is something that is controlling multiplication of a normal cell, whereas a cancerous cell is a problem because, as we know, it's an uncontrolled proliferation. And the problem is the cell refuses to die, but unfortunately, the person who harbors these cells dies. So normally the cells should function; they should stay where they are. Like a lung cancer, a lung cell has to stay in lung, and it has to perform the function of respiration. Whereas if it multiplies to that an extent that it starts spreading to each and every part of the body, then it's a problem. So this is the paradox where our own cell gets the capacity of immortality, and then we become mortal. So why should cancer be a problem? So we understand if it's heart attack, heart stops functioning, and the blood pumping is not there, and we die. And if it's cirrhosis of liver, we know why we are going to die. But why should we die in cancer? So cancer as such is a very innocent thing unless it starts replacing vital organs. So for example, if you have a breast cancer, so breast cancer is not that lethal when compared to a lung cancer, because lung is a vital organ. So these cancer cells start spreading to these vital organs, and they start replacing all vital organs. So it hampers liver function, it hampers lung function, and then the patient gets convulsion, goes into coma. If it's in brain, if it's in bone marrow, it starts replacing the normal bone marrow cells, thereby hampers the production of normal blood cells. So the problem is it starts replacing vital organs, and it hampers vital organ function, and that's why cancer is lethal. So cancer as such is not lethal, but it starts interrupting functions of vital organs. So therefore, if we have a cancer, we always look is the origin is in a vital organ. For example, you have a sarcoma of a limb. You can easily get a higher cure rate because until and unless it is not spread to the vital organs, you can just get away with resection and some chemo or whatever therapy. But if you have a lung cancer, it's not easy to get away with it. Or if you have a brain tumor like glioblastoma, it's not, because the primary is in the vital organ. So whenever we see any cancer for that matter, we always see what is the magnitude of vital organ involvement. So that decides whether the patient is going to die or not. For example, we have breast cancer, a patient with breast cancer who has only bone only metastasis. This patient is going to do well because bone is not a vital organ. The patient is going to live long. Therefore, that breast cancer where the disease is confined only to bone only mets versus a breast cancer where it is involving liver and lung, there comes the difference in survival. So there comes the difference in outcome. So whenever I look at a cancer, I always look into whether my vital organ is at stake or not. If it's at stake, then the survival comes down very sharply. So we all know how do we treat cancer. Cancer is a bad cell. It multiplies, it starts spreading, and it replaces normal tissue. It interferes with normal functioning. Uh, so the best way to treat any bad thing is just cut it out and resect it out. That's what we say about surgery. And supposing if it's a breast cancer, like mastectomy done and you're done with it. Supposing if it's in an area where you cannot resect it, for example, it's a brain tumor or it's in vicinity to structures where you cannot operate, or it's a laryngeal tumor where you want to preserve the voice box, you would like to preserve the structure by giving radiation. Supposing if it's metastatic or you want systemic effect, then you have chemotherapy. So the problem with chemotherapy is I am giving the same drug for all the population, and we don't know whether this drug works for everybody. So is it that one size fits all? So the same paclitaxel, carboplatin, or anthracycline I'm giving to all breast cancer patients. I don't know whether this particular drug works or not. Whether it works or not, you have to give it, and that's how. So it basically works on all rapidly multiplying cells, irrespective of the origin. So the problem with chemotherapy is I am giving one drug, and that has to work in everybody. The same paclitaxel, the same anthracycline I am giving to every patient, and some respond, some do not respond, because we don't know whether that size is fitting them or not. So that's the problem with chemotherapy, where it's very non-specific. It acts on all multiplying cells. It acts on hair follicles, therefore you get hair loss, and it causes exhaustion of the RBC, the production, blood cells get exhausted, therefore you get fatigue, and the mucosa sheds and you get diarrhea, and nausea, vomiting is a big problem with chemotherapy, as we all know. So this is because we are looking into one size fitting into everybody, and it's harmful to the normal body parts, whichever is multiplying, and that's what is all about chemotherapy. So this is one of the inspiring posts. One of actress had posted how chemotherapy causes. She had a neuroendocrine tumor and she has a scar of surgery followed by chemotherapy, and that's what chemotherapy does. So it does benefit, but it comes with side effects. So we have moved beyond a conventional chemotherapy of one size fitting everybody. So now we have learned how to personalize treatment as per the nature of an individual. So as we know, cancer is not arising from outside; it is from one's own body. So when this is so, each cancer is so personal and it is so individualized. So one size fitting everybody is a very crude way of looking into it. Anything that multiplies, I'm going to deal with it. It's a very crude way of looking at things. So I need to understand the biology. I need to understand what type of tumor, what type of genetic makeup that particular cancer has. For example, you have two patients with lung cancer, one a young lady of 35 years and the other one 70-year-old man. The two of them have completely different biological, even though the site of origin is the same, even though the histology is the same, uh, the genetic makeup is completely different. One of them works excellent with targeted therapy, like a simple tablet like Jeftinib or Lartinib, whereas the other patient will require immunotherapy. So the site of origin doesn't matter at all. whether it's lung, whether it's renal, whether it's, so what is important is what is the underlying driver mutation, and that is what matters. So the the cancer is as personal as your tastes, as your behavior, as your genetic makeup. So oncology is more becoming personalized, identifying the genetic makeup of each and every individual, and accordingly modify, customize, adapt, and tailor treatment. So this is again what is personalized cancer treatment. Whenever I have a pool of patients, for example, lung cancer, I would always want to figure out which category this particular belongs to. I'll do a molecular profiling by next generation sequencing, and I'll find out which drug fits whom, what is the underlying driver mutation, and accordingly I'll be able to give. So with this, I can attain an excellent survival and excellent outcomes. So this is what we call as targeted therapy, and we have moved beyond conventional chemotherapy of one size fitting all. So identify the target, the what we call as the magic bullet, and kill only the cancer cell. In contrast to chemotherapy, where all the multiplying cells are affected, whereas in targeted therapy, only the cancer is affected. So this is what we call as biomarkers to identify which drug to be given for whom. So for example, if I have a breast cancer, I will look into whether it's hormone positive, whether it is HER2 positive. So biomarkers make a heaven and hell of difference, and it will help me to choose which drug I have to give. Also, it will help me to understand how long the patient lives. For example, a patient who is hormone receptor positive metastatic breast cancer will anyways have a survival crossing 2.5, 3 years, whereas a patient with a HER2 positive or a triple negative breast cancer, if you are not giving proper targeted therapy, the survival is less than a year. So it's very important to understand the biology of that particular disease, to understand the genetic makeup of that disease. With that, we can say how long the patient lives and what the patient needs to be treated with. So in coming few slides, I'll be giving some examples as to how biomarker-based therapy has changed the outcomes in cancer. And this is one of the excellent examples. We have been reading this from +1, +2 onwards, CML and imatinib we have been reading, and it's an excellent example how a biomarker-based therapy has caused difference. So if you look into the leftmost, it is a normal peripheral blood smear we have done in our first year undergraduate times, where we look into our RBC and we find the WBC, we count the lobes, and look into the middle one where what we see, the WBC is just sitting around, and the WBC count will be something around 2 lakhs, 3 lakhs, and you have a garden party appearance. So this is the disease what we had, where a patient comes to you with a large spleen, weight loss symptoms, and WBCs around 3 lakhs. And what you look is just a simple blood test. Look into whether there is a 9, 10, 22 translocation by FISH or a PCR. And if that is there, you give a proper targeted therapy with imatinib or whatever BCR-ABL inhibitor. And this is the difference you have. So if you just give chemotherapy, just to introduce these Kaplan-Meier curves. So if I had 100 people surviving at time 0, if I just followed them up over a period of time, like 6 months, 12 months, 18 months, so you can see people keep dying as they progress. And for example, at the end of 5 years, if a patient is on chemotherapy, you can see only 50% or less than that people surviving if a patient is on chemotherapy. So this is what we call as median survival. So with chemotherapy, you can see many people dying, and that is not the great way to go. Whereas if you look into a targeted therapy, or if you use a drug like imatinib or Gleevec, look at the survival, it's above 90% even at the end of 6 years. And this is an excellent landmark. So this is blood cancer, and the patient is just surviving with one tablet once a day, just like diabetes and blood pressure. He just makes through having normal life, and look at the survival above 90% at the end of 6 years. And this is what we have learned so far. So if you look into the median survival of cirrhosis of liver, if you look into the child pug A, B, C, so look at the 1 year survival of a child pug C cirrhosis. So 38% 2 year survival. So less than 1/3 of people surviving at the end of 2 years is cirrhosis. So whereas we take cirrhosis of liver quite lightly, that's fine, keep seeing in the medical wards, and that's fine. So The moment you have CML, blood cancer, you start attaching a stigma to it. And you could see the previous slide, look at the survival, 90% survival at 6 years. Look at the survival of a child pox cirrhosis at 2 years, less than, it's around 38% survival with whatever best supportive therapy you can give. So what I would suggest to all non-oncology guys is just take out the stigma that cancer is lethal. So this is a live example of having a patient with blood cancer having 90% survival at 6 years versus a cirrhosis of liver not even surviving 2 years. So more than 50% of them are dying within 2 years. So that is how lethal the disease is. Similarly, you can see a patient with heart failure, how you can see the survival. So majority of them are dying within 2 years. The survival just comes down. So cancer is far better than having a heart failure or cirrhosis of liver or a chronic kidney disease of a patient on dialysis, especially if you have a end stage renal failure. We can see the survival just drops down drastically. Or just a simple patient with dementia where you just don't get anything in MRI, just atrophy, and that patient will not live long. Look at the curves, just drastically fall down. So cancer is lethal, I agree, but look at other diseases where all the vital organs are at stake, whether it's kidney, whether it's liver. The survival is far less when compared to any of the cancers for that matter. I'll be showing in future slides. So this is a COPD-corpulomonale where lung is at stake, and look at the survival of a blue bloater just drops down. So uh, so you could look at a CML curve and you can look at a COPD curve, how the difference in survival is. So we take COPD lightly, saying that that's fine, just inhalation and some Derifilin tablets, and that's the way to go. But look at the survival; it is so short. We don't realize how short these guys live. So to add few more examples to success stories in oncology and the targeted therapies, this is another example where we have translocation 1517 acute promyelocytic leukemia. So what we learned, around 10 to 15 years before, where we had no targeted therapies, the patient just comes to you with low platelets, 2000, 3000 platelets, and the patient bleeds and the patient dies with DIC. You don't know time, you don't even know what is happening, and we just label them as blood cancer, and that's all. The story is over. So now what we have learned in picking up acute promyelocytic leukemia. So it is again, this is because of translocation 1517. The way we saw 922 translocation. If you have 1517 translocation, there is a differentiation block beyond a promyelocyte. If you remember, the hematopoiesis promyelocyte is a precursor, then it becomes metamyelocyte, myelocyte, and mature neutrophil. So there is a differentiation block. So there you tend to go into a sort of a pancytopenia like a picture. There is no multiplication. The marrow is replaced by these promyelocytes. So if you can target that PML RARA fusion which is there, translocation 1517 which is there, and if you can inhibit it, and if you can cause a differentiation with a drug called retinoic acid or arsenic, the patient just gets back to normalcy, and this is the survival we have with arsenic or ATO tablets, just a tablet, and look at the survival. So we have tackled that deadly disease where we had a survival of less than a month or less than a couple of months, where the patient did bleed with the IC. So just by sending a simple blood test like a PML RARA fusion by FISH or PCR, the moment to get the report and giving them uh, this retinoic acid, there's nothing but an altered vitamin A tablets and targeting the PML RARA gene, and look at the survival. It just flattens out, and the cure rate is above 90%. So this is what we have achieved by personalizing cancer treatment, and these are live examples of true success stories of cancer therapy. So we have seen CML, we have seen APML, and we have seen how cirrhosis, COPD all behave. So let us come to an example of lung cancer. So I was just mentioning you that a 35-year-old lung cancer is different from a 70-year-old lung cancer. This is because this is the heterogeneity of lung cancer we have. So one lung cancer can have multiple driver mutations. a young lady will have a EGFR driver mutation, whereas an elderly guy will have a PDL1 positivity. So whenever there's a lung cancer, the first thing I would like to do is get a tissue out of, get the cancer tissue, adequate tissue, not to diagnose, but to find out what is the underlying driver mutation in this patient. So nowadays we also have a liquid biopsy where to just give a blood sample for a comprehensive genomic testing and find out what is the mutation underneath. So if you have a EGFR mutation patient, look at the survival, median survival, that is 50% surviving. It's nearly, it's crossing 3 years. So there was a time where lung cancer, we were thinking, if it's an very unfortunately majority of lung cancer, nearly 70 to 80% of them present with advanced stage, because we are not symptomatic until we have a stage 4 disease. So there was a time where we were thinking, giving any treatment is worth at all for these lung cancer patients because they're anyways going to die. And then we had this platinum based chemotherapy, where it added some survival reaching up to 6 to 9 months. And now look at the survival. So more than 50% of them just crossing the 3 year mark so easily. And what is the treatment we gave? Just one tablet once a day, just like blood pressure and diabetes. So you didn't have a cirrhosis surviving, you didn't have an COPD surviving just with one tablet. And the rapidity of response is also so excellent. The quality of life is excellent. So this is a curve of an advanced lung cancer who would have otherwise died within 3 months, just 10 to 15 years before, and now one tablet a day, and you have a survival for more than 50% of them surviving more than 3 years. And the tail goes on, and you can look at the tail of the tail. It just is parallel to the baseline. That means these guys are going to live long, more than 50% of them. We don't see with any organ damage, with any disease for that matter. Even a CKD on dialysis won't survive such well. So this is what we have achieved in lung cancer. So then coming on to some examples of breast cancer, and this is an example of a HER2 positive breast cancer. So before we had HER2 directed therapy. HER2 is a driver mutation that is there in a cancer cell where there is autogenous proliferation of cancer cell without any stimulus from outside. So so if I'm giving HER2 directed therapy like a trastuzumab or a pertuzumab based therapy, and look at the median survival, it's just 56 months is the median. 50% of them are alive at 56 months, nearly coming up to 5 years. And look at the parallel. The lines are parallel. They're not coming down. So we are practically curing. So I don't know what you call cure. Nobody is going to be on this planet forever and ever, but these guys are living 5 years without any difficulty. Then these are terminal breast cancer patients who had multiple liver, lung mets, brain mets, and they're doing so well. So this is what is a personalized cancer treatment can do. If I would have given only chemotherapy, we would have lost these patients less than a year. So few more examples of targeted therapy. So we had targeted therapies targeting the cancer cells, inhibiting proliferation. We have some targeted therapy where we don't target the cancer cell. On the other hand, we inhibit the blood supply to the cancer cell, and therefore the cancer cell just shrinks away. So this is basically a VEGF inhibitor, or what we call as inhibiting blood supply, cutting down blood supply to these cells. So if I give bevacizumab, which is an anti-vascular endothelial growth factor, it just shrinks the tumor away. It has got no direct effect on cancer, whereas it just cuts the blood supply to these cells. And this is the result with bevacizumab, where it has improved survival in colon cancer. If I'm giving, you can see the line becoming parallel again here. So it doesn't fall, the line just stays parallel to the baseline. You can see nearly 35-40% of advanced colorectal cancer patients surviving long term, more than 5 years. So this is a slide just to say, just in lung cancer, this is the number of genes that is possible. So as an oncologist, if I don't get updated every day, which is the new gene, which is a new target, it's very likely I'm going to miss it. So one, so even if I relax for a month of time, what are the new targets and what are the new drugs? I'll not be doing justice to my job. So this is the number of genes present just in lung cancer. And look at other cancers like sarcoma, breast cancer, brain tumors, for any other mutation. So nowadays, what is coming up is a tissue agnostic indication. Don't care from where the origin of cancer is. Look into the driver mutation underneath. I don't care whether it is from lung, kidney, bladder, wherever. I just want to know what is the underlying driver mutation. This is what is called as a tissue agnostic indication. So we have some mutations like NTRK mutation where or a microsatellite instability. So we don't care where the tissue of origin is. I don't care whether it is lung cancer. I don't care whether it is breast cancer. I just want to know what is the underlying mutation. So this is what is called as a tissue agnostic approval of drugs like immunotherapy or NTRK inhibitors like entrectinib in this. So this is the list of genes, and the gene list increases. So rough estimate is around 250 to 300 genes are there with specific targets. We have approved targets targeting these mutations, and that becomes extremely important. So whenever you see a cancer next time, make sure you have a biopsy. Very important. And the biopsy is not to diagnose. The biopsy is to find out what is the underlying genetic mutation. Can I fit in with some drug? Do I have an approved drug for this? So the moment you target the particular mutation, the survival just increases dramatically. So then coming on for a few words on immunotherapy, and these are the guys who got Nobel Prize a couple of years back for finding out for discovering immunotherapy, and this is how immunotherapy works. So we know HIV is an immunosuppressive disease. It destroys T cells. Mind you, cancer is nothing less than HIV or AIDS. It causes T cell energy. It causes immune suppression. So cancer is an immunosuppressive disease. The T cells are just nullified by these cancer cells, by the receptors, and this is how cancer cell overcomes immune surveillance. So normally our CD8 cells, they always fight and they kill the cancer cells, and these cancer cells have certain techniques involved in them where they nullify the effect of T cells and they cause T cell energy. So we know HIV gets into T cells and destroys all CD4 cells, and therefore you get infections. So nothing less, cancer is similar. It causes T cell destruction and it causes T cell energy. So if you can revert it, if you can prevent the interaction between a T cell and a cancer cell, you can edit the edited immunity by the cancer, and you can make the immunity active, and this is what we call as immunotherapy. And this is a few examples of this. Is the PD1 and the PDL1, that is the programmed death one, programmed death ligand one. And now if you can block this interaction, you can allow the T cell to kill the cancer cell. Similarly, CTLA4 is cytotoxic T lymphocyte 4. Again, block the interaction. Again, you can prevent or intervene with cancer-induced immunosuppression by drugs. You get success. And has it translated to clinical success? So this is a melanoma, and melanoma is one of the most painful cancers known to mankind, especially if you have bone mets and brain mets. The patient dies miserably, and this is what we have achieved. Look at the survival. More than 50%, nearly 60% of them just surviving through and through, and the line doesn't seem to come down. This is the beauty of immunotherapy. So immunotherapy doesn't work in everybody. So for immunotherapy to work, you need to have two things. One is the cancer should express PDL1. The other thing is the cancer cells should be infiltrated by lymphocytes. When this combination is there, so cancer cell expressing PDL1, the ligands that are killing the T cells, and there should be T lymphocytes at the site. When this combination is there, what we call as a combined positive score or a T total positive, whatever score we call. So if that is there, and if you can give immunotherapy to this subgroup of patients, these patients are going to have a life just like normal individuals. And immunotherapy hardly has any side effects. This is not chemotherapy, this is not targeted therapy to cause any side effects. The patient just enjoys normal life, and this is metastatic melanoma. And look at the survival. So this was never heard of, that in terminal cancer patient like lung cancer, renal cancer, or melanoma surviving 4 years, 5 years. This was never heard of, and this is a surprise for all of us. And that's the reason why Nobel laureates are there with the discovery of immunotherapy. So this is a success that we have went through over a period of time where we have practically changed almost a lethal, near lethal, or a disease where a death statement was attached. The moment you said cancer, in all movies, you can see the patient is dying stage by stage, you know. So we have changed the natural history of disease by intervening into the roots of the genetic basis and by improving the immunity. And this is what is targeted therapy and immunotherapy has done. And so before I finish my talk, I would just want to give few take-home messages. Cancer doesn't mean death. Please take out the stigma, because you have seen a cirrhosis patient, you have seen a COPD patient dying so soon. You have seen the survival curves just dipping down so fast. And chemotherapy with one size fitting all is gone. So we have come far beyond that. It's all about targeted therapy and immunotherapy. I must always do a biopsy whenever there's cancer, not a FNAC. I do a biopsy not to diagnose it, but I want to find out. I don't care which site the origin is. I just want to know what is the underlying genetic mutation. Can I target this or not? So if I can find out a target and we have a targeted drug for it, and if I can give either targeted immunotherapy, these terminal cancers are going to change to diseases like diabetes and blood pressure with one pill a day, or like one injection a month, and the patient enjoys life just like normal individual. So you may not even know your colleagues or people around you may have cancer and they may be on these tablets. You may not even know. So that is what revolutionary thing that has done with advances in cancer treatment. So with this on World Cancer Day, so I would thank everyone for your patient listening. And I would again thank Abraham, and I would thank Believers Church Hospital to provide me the opportunity to talk few words on cancer. Thank you so much, and back to you for organizers. Yeah.
What an appropriate talk on today's day when we celebrate World Cancer Day on the theme I am and I will. Thank you so much, sir, for that wonderful presentation. Good evening to all our listeners from the medical fraternity, all those who follow us, our webcasts and webinars on the social media, and all those who constantly encourage us to organize this continuing medical education programs. We at Believers organizes these webinars under the patronage of our distinguished director, Dr. George Chandi Matitra, and is materialized by Dr. Jacob Jesuron, who is the Dean of Student Affairs and the head of the Department of Pharmacology at Believers. Today is our 49th webinar. It's been a long journey, and we are slowly marching towards the Golden Jubilee webinar on the next talk. Today's talk is being moderated by our own consultant medical oncologist, Dr. Abraham Samuel. Dr. Abraham Samuel is not usually seen organizing these webinars, because right from the time I have known him, his only motto is patient care. He'll be always seen in the wards delivering patient care day in and day out, day and night. But today we're fortunate to have him here. May I welcome Dr. Samuel now to say a few words on the topic, to introduce the speaker once again to the listeners, and to conclude this session.
Abraham, you're muted. Yeah. Not audible.
Yeah, I think you're muted. You're muted, I think. Yeah, you're audible. I think there's some technical issue there.
Yeah, that's fine. You can conclude.
Yeah. Right, Dr. Abraham, can you try coming in?
Thank you, Dr. Renji, for introducing and inviting me to this as an moderator for the session. As we all know, Dr. Chandrakant is my batchmate during my DM training program. He was always an excellent speaker, as well as he's had brilliant academic records to his credit from his right from his undergraduate days to this specialty training period. He has many international publications and national and international publications to credit. He's a highly skilled, astounding clinician who is as well as he's an eminent oncologist. He's right in the field more than a decade from since he started his training program. Dr. Chandrakant is currently working in Narayana Hrudayalaya Hospital, Calcutta, as a consultant medical oncologist and hemato-oncologist. He treats all type of malignancies, including hematological as well as solid tumor malignancies, and also do transplantations. Thank you, Dr. Chandrakant, for coming here and accepting our invitations. Though you are in a busy schedule, you're taking care of patients, and thank you for coming here. And I'm right now I'm not able to see any questions directed to our speaker. I hope there is no questions coming from now. Thank you, Dr. Chandrakant, for once again on behalf of me and the Bevacizumab Hospital for accepting our invitation and delivering this excellent, simple, excellent, but it is very straightforward and I think it's very interesting session. Thank you very much for coming.
Thank you.
Thank you, Abraham, sir. Before we sign off, I would also like to inform you that the Golden Jubilee webinar, the 50th webinar of the series, will be day after tomorrow at 6 p.m. The topic will be Introduction to Forensic Psychiatry. The talk is going to be delivered by Dr. Rajesh Jacob. He's a senior consultant psychiatrist from Winslow Clinic. And the talk is going to be moderated by Dr. V.V. Pillai. He's a professor and head forensic medicine and toxicology at Amrita Institute of Medical Sciences. As I already told you, it has been a long journey. Lots of people are there behind the conducting of these webinars, and we are all joyful that we are moving towards the 50th webinar of this series. I personally congratulate Dr. Jacob Jasurun, who has been the cornerstone in organizing these webinars. So we all hope to see you at 6 p.m. day after tomorrow for the Golden Jubilee webinar. Once again, thank you, Dr. M.V. Chandrakant and Dr. Abraham Samuel. Thank you so much.
Thank you. Thank you. Good night.